in case. Okay, go ahead, Dr. Adam Sewell. Sewell, right? Did I pronounce your name right?
Yeah, it's Sewell. Yep.
Sewell. This is Chronic Disease Prevention Management Fellowship. It's a CME credited from American Medical Association. You have 2 hours. The link for the CME, it's there in the website. Please, everybody, get your CME if you want to get your license renewed. And I would like to hear more about Dr. Adam himself. Introduce yourself and your profession and what you do and how you feel about our room. I mean, it's basically my room. It's all about debating, discussion, and advancing innovation. It's an open room, but we will give you the platform at the end of the lecture. We want to also have that debate and discussion to entertain the doctors here. And there is no way of learning by one way. It needs to be discussion, debate, and brainstorming, and verifying information that's being received by 20 or 17 or 18 people that's attending in this meeting. So go ahead. The mic is yours, Dr. Adam.
Okay, thank you. So today, what I have for you is I'm first off, my name is Adam Sewell. I'm a medical doctor. I'm triple board certified anesthesia, pain, and addiction. I primarily focus on what would be considered regenerative medicine now. Most of my practice is very high-end athletes, celebrities, musicians, that kind of thing. And what I wanted to do today is I wanted to bring you the science of joint regeneration that I've been using in my practice and actually share with you the models that are used and kind of like, just listening to this discussion that happened, initially. I think one of the issues that happens in medicine is that very often people say, "Hey, I use X, I use Y, I use Z, and you should use this because I use it and it's worked on this patient or that patient." One of the things that we have to do as physicians is to make sure that we have a clinical model that we can use. And by creating a clinical model, then that will show us what products are necessary to use and exactly how you can treat various disease states and even modify our own physiology. And so today, what I'd like to do is I'd like to show you what the most recent research has shown on what we understand to be a joint, the model of a healthy joint versus the model of an osteoarthritic joint. What is changing and how, now we have a different understanding than we had in the past, where now we have an immunohistochemical understanding of, what is actually occurring inside the joint, and that allows us now, with that model, to be able to make interventions to change the way that people have, joint pain, to change the fact that people have osteoarthritis, stop the progression of osteoarthritis, and even reverse the progression of osteoarthritis. This is something I do all the time in my practice with a lot of different, various products, but I want to show you exactly how you can do it yourself and use these models because I think you'll find these models to be very useful and it allows you to find the truth, which is, if you take 100 doctors and put them in a room and ask them to solve one patient problem, you'd find that there are probably 100 different ways that you could solve that problem. There's many, many solutions to the same issue. And so by building these models and sharing these models, what you'll find is that this will explain why there are so many solutions to the different issues. And with this model in mind, then you'll know exactly what to do and when to do it. So who is this for? Basically, if you're a physician, nurse practitioner, physician assistant, somebody who's in healthcare, who's interested in this. And what we're going to talk about today is just understanding the physiology and the immunohistochemical model of a healthy joint. What happens to make that healthy joint become an osteoarthritic joint, and what happens each stage of that. And then we're going to talk about evidence-based interventions and things you can do if you wish to help patients with that. So just kind of get started, and I know a lot of this may be a little bit of a review, so I won't, spend too much time on it. And then at the end, we can answer any questions you have. But basically, this is a normal model of a healthy joint. We know that, healthy joints maintain, articulating bones. They're obviously alignment's important. We know about, cartilage. We know about, various synovial fluid, et cetera, in the joint. Kind of continuing on with the mechanical model. We know that most of the joint has a lot of hyaline cartilage, which is avascular. We also got, proteoglycans, et cetera. This is all stuff that is fairly well understood and has been understood for many decades. We also know synovial fluid is really important. We know that it's, produced by the synovial membrane. We also know that the fluid's very critical in the way that joints are lubricated, and that synovial fluid plus many of the proteoglycans like aggrecan are really critical to have a joint that functions well. We also know that there's tendons and ligaments around joints. They're really critical, and this is what I see a lot with the NFL guys, right? Very often, if you look at an NFL guy that gets injured, they get many, many damages to their tendons and ligaments that usually come before they ever have an issue with the actual primary joint. Because as we start to study a lot of the models of a healthy joint, we see that those tendons and ligaments are actually more critical than, initially we probably thought. We also know that muscle support's ultimately very, very critical. We know just from our other research that, essentially the amount of muscle someone has is directly proportional to their survivability. And when it comes to joints, that's really true as well. The reason why an NFL linebacker can get hit with, 1,000 pounds of pressure on the side of his knee and then walk away from that, whereas, the average patient, the average Medicare patient at the age of, let's say the average Medicare patient would, have their joint ripped apart. A lot of that has to do with the muscle support around the joint. We also know the joint capsule is really important. We know it's lined with synovium, and that synovium is really critical to make that liquid, right? To make that synovial fluid. So, kind of diving into kind of the more recent research, we're going to talk a little bit about the what's called the immunohistochemical. It's a mouthful, but basically, what do we see on the cellular level? Like, what's actually making all this stuff work? We know that chondrocytes are basically cartilage cells. We know they have specific markers like SOX9. We know that they have transcription factors. These transcription factors allow these chondrocytes to build, collagen type 2, aggrecan, etc. We also know that there's synovial cells, and there's actually two types of them. We know that type A synoviocytes are kind of macrophage-like, and they eat up a lot of the debris in our joints. And we also have type B, which are more like fibroblasts, and they actually produce hyaluronic acid and lubricin. And we know that there's markers that we can measure inside the joint to determine the processes that are going on in the joint based on these different activities. We also know that there's macrophages and immune cells that are in the joint as well, and we'll talk a little bit more of those, particularly as we start to explore how the healthy joint becomes an osteoarthritic joint. We know there's a lot of vascular markers. The joints themselves require a lot of nutrition, and we know that capillaries in the synovium express certain markers like CD13, 31, and VEGF. And there's a lot of things that we can do to measure these, and through the measurement of these vascular markers, we're able to determine the health of a joint as well. And of course, we know that there's many extracellular matrix components. So you got type 2 collagen, which is, kind of the most important part. You got type 1 as well. You got collagen fibrils. And without getting too much into all the technical stuff, we know that the extracellular matrix is really important and is actually one of the first things to degrade in osteoarthritis. We also know that proteoglycans and glycosaminoglycans are really, really critical to how the joint functions and the stiffness related to the joint. Things like lubricin, which is present on the cartilage surface, reduces friction and is really critical for joints to operate normally. And we also know that in most of the healthy joints you see, the levels of inflammatory cytokines are very, very minimal. And what you find in healthy joints is that the inflammatory cytokines like interleukin 1 beta, TNF alpha, IL-6, always very minimal. The anti-inflammatory cytokines like IL-10 and TGF beta are balanced, and we'll see a little bit more, especially about TGF beta, because that's a big one that we can manipulate to help joint health. Um, are really balanced out to kind of make a system where we can essentially help the joint health. TGF beta is actually really critical, and we'll see more of it coming forward. But it's really critical in the homeostasis of the joint and making sure the joint regenerates. We know that in a healthy joint, there's a lot of, there's very minimal cell apoptosis, like cells are not dying, they're not killing themselves. And so therefore markers of things like caspase-3 are not really present in healthy joints. However, in osteoarthritic joints, we see quite a bit of this. And so the reason why I went through all of that is I know some of this may be kind of a review, but the important thing is to realize because of a lot of our ability to work at a molecular level now, we're now able to generate a new model of osteoarthritis. And this new model of osteoarthritis will walk through what we see the changes that occur from a healthy joint at each stage of osteoarthritis. And then at the end, we'll say, okay, based on these changes that we see, what can we do to make interventions? And I have an entire list of the interventions that are, basically, somewhat evidence-based and things you can do to help with those. So just looking at early stage arthritis, we get some mechanical changes within the joint right away. You also see the cartilage starts to soften, mainly because it starts to get what's called matrix degradation. And you can sometimes see this when on some really high quality MRIs, like a 3 Tesla MRI or 3 Tesla MRI with a prism, which makes it actually closer to like a 4 Tesla. You can start to see this at the end of the early stage of osteoarthritis, where you start to see reticular patterns showing up in the articular cartilage. And so sometimes you can catch this, most of the time you can't. But we start to see that there's a softening of the actual cartilage. And then we start to get basically fibrillation, which are essentially fissures or divides that are within the cartilage themselves, particularly on load-bearing areas. And this is what is typically seen when you see a reticular pattern of articular cartilage. It looks almost like, reticular meaning reticle, like a reticle that might be on a scope. So you see almost like a little cross of a reticle. And so these things that you can actually catch these every once in a while in patients, especially if you have a very high quality image. Of course, the thing we always see with osteoarthritis is joint space narrowing, right? And that starts in the earliest phases of osteoarthritis, and that gives us some kind of hint that, hey, something's going on and this process is destructive. And then we also see that there's, of course, reduced synovial fluid, which is why we get the joint space narrowing, right? So we know that, decreased levels of lubricant and hyaluronic acid, they affect the shock absorption of the joint, and that basically you have this important chemical, and we'll hit on this a lot more, called TGF beta, and it basically is essentially in the early phase of osteoarthritis, attempting to sustain the status quo, attempting to stimulate cells to grow and to help maintain the homeostasis of a joint. Later, though, that TGF beta actually becomes bad for us, and I'll show you exactly why. This is a pretty complex diagram here, and so for the interest of everybody here on the call, I don't want to have to go down and break down all of this. But basically, the important thing to see here is that in early stage osteoarthritis, we have TGF beta, and you can see there's a green side and a red side, right? On the green side, basically what we see is that we have essentially all the good things that happen with a low level of TGF beta. If TGF beta is low, it's good. If TGF beta is high, it's bad. And so in early stage osteoarthritis, many times TGF beta is low. As the initial stage of osteoarthritis starts to move to the moderate stage of osteoarthritis, we start to see the TGF beta starting to cause problems. Not that it was meant to do that or not that it was trying to do that, because normally TGF beta actually promotes extracellular matrix repair. So as the cartilage is starting to get softer, starting to degenerate, TGF beta is actually stimulating the body and the joint to actually encourage chondrocytes to make more collagen type 2, to make more proteoglycans, and to make a better cartilage all in all. It's essentially stimulating the cartilage to grow and try to repair the defects that are occurring from the osteoarthritis. Here's a more of a complex picture of exactly how TGF beta, and there's actually multiple subtypes of TGF beta, so not to go like too far into the molecular of all the stuff, but basically TGF beta essentially binds the chondrocyte receptors, and these chondrocytes are then stimulated to basically promote extracellular matrix synthesis. And it's the chondrocytes that are basically, they're also expressing cytokines like interleukin 1 beta and TNF alpha in response to minor damage, which are useful initially in low levels. As things progress with the early stage osteoarthritis, we start to get MMP or metallic matrix proteins and anti-inflammatory effects that are occurring. And we know that these expressions of like MMP1, MMP3, and 13, they actually try to regulate the ECM turnover. And TGF beta initially at a low dose has an anti-inflammatory effect and actually encourages M2 macrophage phenotype. And we'll talk a little bit more about the macrophages and their shifting as things go on. But important to see that there's TGF beta initially at low doses actually stimulates an anti-inflammatory response to osteoarthritis initially, um, which is kind of critical. However, as time goes on, that changes. We also see in early stage osteoarthritis, if you take a sample of the synovial fluid, you run it through molecular analysis, what you'll find is that you have very, very mild or very low levels of inflammation, like the most common cytokines that are associated with inflammatory response. are very low. You have TGF beta, which is moderate to low. And you can see in a healthy joint, all of these different cytokines are balanced. And when they're balanced, they allow for homeostasis of the joint. You can see when those become unbalanced, where you have more of the inflammatory cytokines and less of the anti-inflammatory cytokines, you go into what's called joint catabolism, and the joint starts to eat itself. And this is what really progresses osteoarthritis, right? Is that basically we have this unequal balance. And what I'm going to show you today is how to fix this balance in each stage of osteoarthritis. And as simple as that sounds, saying that, you can see there's some complexity to this, but I want you guys to have the skill set because once you understand this model and you understand how to intervene at each stage of osteoarthritis, you can literally take someone who has osteoarthritis, stop their arthritis like this, and start to repair it. It sounds kind of maybe some people say, "Oh, I didn't know that was possible," or "Why didn't I learn that in med school?" There's a lot of things we didn't learn in med school because we were very much focused on, kind of a curriculum that was designed, by someone else, not so much what's best for the patient. But the thing is that just from the research I'll show you here, and I'll also include references, so you can, please research it yourself, go through the studies, you'll see that all the stuff proves out. But just from the ability to balance this cytokine picture, you can help people so much. And our current mainstream medical treatment of osteoarthritis doesn't balance this at all. It covers this up, and then it basically waits until it's time for intervention. And most of the things that are actually useful to do that are not commonly used, which is really sad because a lot of them are very, very cheap. Some of them are, basically derivatives of the patient's blood that you can use. I'll show you guys how to do that if you want. And then some of them are more expensive, right? We have all sorts of other things, but it's amazing that our focus whenever we see a patient with osteoarthritis isn't balancing this, isn't even testing this, isn't even figuring this out. It's to give them anti-inflammatory medications, which have a whole host of other side effects, as we all know. And then, telling them things like, oh, wait until your knee needs to be replaced, which if you have patients that have been through mainstream medical system, that's often what they're told. So when we start to advance to a moderate stage of osteoarthritis, you can see here, this is the moderate here. So this is early, moderate, and late. We start to find a couple things change. One is we start to see pretty significant cartilage erosion. At this point, the cartilage isn't soft anymore. It's degraded a lot. It's starting to really, really start to degrade. You can see this on images very clearly in moderate stage osteoarthritis, especially if you have a good high quality MRI. I recommend that everybody use 3 Tesla or better. And better meaning using a prism with 3 Tesla, which are only available at some academic centers. But 3 Tesla is usually a great, great quality MRI. And compared to 1.5, the quality of the image that you get is so much better. And you can actually see exactly where these erosions are occurring, which, by the way, can help you in your treatments depending on what you're treating with. Obviously, with any kind of osteoarthritis, you're going to have some pretty significant joint space narrowing. At this point, it's starting to get pretty bad. Initially, it was pretty small, not a big deal in the early stage. Now you're starting to notice it pretty significant. And this is why a lot of the interventions we have can help that out. You also begin to see some osteophyte formation. This is a complex diagram here, but basically what's occurring is that because of TGF beta, initially when TGF beta is released in the early phase of osteoarthritis, at the very beginning, it has a benefit. However, as we go towards the end of the early osteoarthritis phase and start to move into the moderate osteoarthritis phase, TGF beta actually hurts us. And TGF beta is actually drives a lot of things, including osteophyte formation, which is interesting because you can actually reverse osteophytes in patients and you can stop osteophytes from getting better by modifying TGF beta. And I'll show you how to do that later. The other thing that occurs in a lot of these joints, and you can feel this in some cases on some patients, especially if they're thin and you can actually feel their joint, the synovium starts to thicken. You'll notice that patients that have a lot of osteoarthritis, their joint is literally thicker than patients that don't have it. And so you can sometimes feel this with needles as you go through joints. You can get a little sense of this. But basically, because of TGF beta signaling, what's actually occurring is you start to get an inflammatory response and you start to basically contribute to fibrosis. There's literally fibrosis that's occurring in the joint. And this is really critical to stop fibrosis, as you might imagine, because not too many good things come from fibrosis, right? almost every area of the body that we have fibrosis in, it's usually not a good thing, and in the long term damages the tissue. If you look at it from a immunohistological chemical kind of viewpoint, what you find is that the TGF beta levels rise in the synovial fluid. And you can test this, by the way. You can take a sample of synovial fluids and send it to the lab. They can do a test that can tell you that all the levels of the cytokines in the fluid, if you ever wish to, and that will give you the most accurate view. And I promise you, if you do that, a patient has never had that done to them ever. Like it's mind blowing to me that many times we have all this technology available to us, yet we hardly ever use it, you know? But basically, as the TGF beta levels are starting to really increase, and what's happening is that they are meant to promote repair, but what ends up happening is they're actually contributing to the fibrosis. And they remember how they have the two different types of synoviocytes, right? You have the one that's kind of like a macrophage, one that's kind of like a fibroblast. The TGF beta starts activating the fibroblast one more than macrophage. The macrophage one is supposed to eat up, debris and stuff in our joint. That's all great. But we start to go heavy on the fibroblast. What happens? We start building scar or fibrosis, right? And that's a major problem. That's why when you look in a lot of joints, if you look at the MRIs of patients that have, moderate to severe osteoarthritis, you'll notice their joint is completely different than people that don't. Oh, sorry, I pressed the wrong button here. Hopefully, you guys see the screen okay?
Mhm.
Not sure what I did there. Let's see. Okay, cool. Got it back. All right. So basically, the other thing that occurs that as TGF beta continues to increase, you start to get chondrocyte hypertrophy because the chondrocytes are being stimulated, 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 and so they start to increase bigger and bigger and bigger. And what happens, which is kind of weird, is they start to increase what's called MMP13 expression, and this is a protease expression. And what ends up occurring is that as that increases, the faster the cartilage gets destroyed. So initially, TGF beta is a good guy trying to help stimulate chondrocytes to repair damage. But if you, just like with anything else, if you continually stimulate something over and over and over, you can damage it, right? If you give somebody one low dose of epinephrine, you can cause a minor effect, but you can give somebody 20 doses of epinephrine, you can cause a heart attack, right? So same kind of deal is happening here. This is kind of a cool picture that I thought was interesting. What ends up happening here is that as you get increased inflammatory cytokines and MMPs, you start to see that what is occurring is you start to see degradation of the actual tissue. So the MMPs actually drive more inflammation and actually degrade the extracellular matrix of the cartilage. And so you can actually see here from day 0 for here's a control to day 30, these are the different stains on the tissue. But take a look at how this tissue degrades. It's pretty significant. Imagine here where you have no issue, and then 30 days later, look at that. And that is related to the fact that you have TGF beta stimulating chondrocytes to express MMP, and MMP is causing the degradation of the cartilage. And so you can see the loss of organization of the tissue, loss of control of the tissue, and with those two things, of course, come loss of function of the tissue, right? So pretty important as we continue. The other thing that is occurring is with the high TGF beta. Remember, we talked about synovial fibrosis. That's starting to go into overdrive, and you start to get a lot of what is was essentially thickened joints. So as the fibrosis occurs, you're getting more and more fibrin laid down. The joint gets stiff, which gets thicker and thicker, and this is why you get patients that have severe joint stiffness, right? The joint itself is actually stiffer than a healthy joint. It's not just their perception. Like literally, the joint has changed because of this. So when you get a patient that's in the end of early phase or moderate phase osteoarthritis and you feel their joint, it feels like a different joint than a healthy joint. Sometimes you can even feel, especially on the knee, you can palpate the arthroscopic windows, and what you find is you can feel it's thicker, it's more dense. This is because of TGF beta causing these reactions. The other thing that happens is that there's two kind of phases of macrophages, right? So we know that we have a pro-inflammatory macrophage and an anti-inflammatory macrophage. The same macrophage can be activated to either be pro-inflammatory or anti-inflammatory. If I take a normal macrophage in its default state, which is called M0, default state, and I apply certain stimulants to it, then I can make it into a pro-inflammatory or M1 macrophage. And that's the one here on the left. So you can see here how these cytokines, like Interferon gamma, TNF alpha, etc. These guys all stimulate the macrophage to literally change its function and basically release even more inflammatory cytokines and start to behave in such a way that causes tissue damage. Now, in the earliest phases of osteoarthritis, we have TGF beta at a low level. It actually stimulates the macrophages to be what's called an anti-inflammatory macrophage. So if that when that happens, the macrophages themselves are not attacking tissue. They release an entire different set of cytokines. Look at all these here, totally different. Even cytokines like VEGF, which at a moderate to low levels, very useful. High levels may be damaging depending on where you are. But you see here that literally this becomes a cascade. And this is why I want to show you this. I don't want you don't have to sit here and memorize like, oh, M1, M2, macrophage. Don't worry about that. Like the big picture here is that there are certain points that you need to identify, one of them being TGF beta, where basically that one cytokine causes such a cascade that it changes the future of that joint forever. And this is why, as we finish this model, I'm going to show you how you can make interventions and how there's little things that you can do in the joint to modify the entire physiology of the joint. TGF beta is one of them. There's a few others, and we'll go through each of them, and I'll show you exactly how to make interventions depending on the stage of arthritis. I even have a chart for you and everything. So if you want to take notes, cool. But if not, I got you covered. I got a chart for you as well. Um, let's go to late stage osteoarthritis. These are typically the people that I get, right? So unfortunately, I wish I got people in early stage osteoarthritis, but most of the time it's not terrible, and they're going to see their primary care, etc. Most of the time when I get called, it's usually for an acute injury of a person that's usually like I call them a performer, somebody who's a musician or actor or something like this, and they got to perform. Or two is somebody who's had problems for a long, long time, and they're like, I can't deal with it anymore. I had my left knee replaced. It was horrible. Now my right knee is, they're telling me I need to replace. I just don't want to do it because of my bad experience. Please help me. And this is probably the most common regenerative medicine patient that comes through is usually the late stage. Every once in a while, you get some moderates, which is awesome because they're actually easier to deal with. But the late stage of osteoarthritis is really important to know, and probably a big chunk of your patients that you get for regenerative medicine. The reason why they're turning to regenerative medicine is that they've failed on every other therapy that's existing, and they're just like, I don't know what to do. They're telling me they're gonna have to, give a joint replacement, or sometimes even the patients that can't even take a joint replacement. Maybe they're on blood thinners, they have got cardiac issues or whatever, right? So when we look at late stage osteoarthritis, that's going to be a picture four here. What you find here is mechanical changes. You have a complete cartilage loss. The cartilage is usually is completely eroded. And if you were to look with an arthroscope right into the joint, what you're going to find is that you have subchondral bone changes in many areas. You can see here on this picture, maybe not the best picture, but you can see here that like this little kind of light blue is cartilage, right? Is articular cartilage. Notice here on the end, you got this red stuff, right? This red stuff represents exposed bone. Whenever you've exposed subchondral bone, it's a real problem. And the reason why is because subchondral bone is highly irritating, and without any articular cartilage, you have no production of any of the proteoglycans. You have no production of aggregations. You have no defense against the wear and tear that occurs just from the joints just moving over each other. It's extremely damaging. This is why you see people with severe osteoarthritis, they won't be able to move, or they'll decrease their activity where they just basically sit in bed all day or sit in a wheelchair all day because literally at that point, when you have subchondral bone exposed, just for them to move creates a massive amount of inflammation, cause massive amount of pain and damage. And for them, life is very hard. And so, like I mentioned before, unfortunately, there's going to be a big chunk of the patients you get. And so we have to figure out how can we stop that process and reverse it. Here's actually a picture of a late stage osteoarthritic knee. And there's a couple of things you can see here. We got pretty significant narrowing of the joint space. I mean, look at this. They're practically, touching here. The other thing that you see in all stages of osteoarthritis, but definitely see more as the osteoarthritis progresses, is sclerosis. A lot of people don't look at this, but if you have, for example, a C-arm in your practice, if you're able to get x-rays in your practice, you will notice as you look at more and more people with osteoarthritis, one of the first things you start to notice is that there becomes sclerosis that comes right around the joint. In this picture here, the way this x-ray is developed, the sclerosis is more white. If you look at, for example, a C-arm film, or depending on the X-ray machine you use, this may be opposite of that. So, for example, if you look at a C-arm, you're going to see that it's more black around the joint. It looks like somebody took mascara and drew a line around the joint. The reason why that is occurring is that the bone is actually more dense there. It is literally more dense. So when I shoot my X-ray through here, like you can just look at this X-ray. When I shoot here, if I shoot X-ray through the air, it's black, right? On this X-ray. Whatever is the most white is the most dense. If I put a piece of metal on this X-ray, it'll be completely white. This area here, basically of the subchondral bone, the bone that's touching the articular surface of the joint, it's called subchondral bone. That bone is more dense now because there's been so many inflammatory cytokines that have stimulated a shift in the bone that is actually increasing bone density. And of course, you get osteophyte growth like this. Like, see this osteophyte here? You now have new bone growth. So that's what's making this sclerosis. So sclerosis is something that I always watch. Like every time I do an X-ray of anyone, anytime I do a treatment, I use C-arm quite a bit. I'm always looking at the sclerosis, and I try to measure sclerosis from one time to the next, because that will give you an idea of what is going on inside the joint at a cytokine level. The other thing that you'll see is that at this point in late stage osteoarthritis, the TGF beta is a real problem. The TGF beta is now driving osteoblast essentially to cause some chondral bone thickening. And this is where you get a lot of the sclerosis from. You get cyst formations. This is why you see people that get, various cysts. I mean, here's a beautiful picture of a cyst here that's happening. And at this point, whenever you have late stage osteoarthritis, the ability of the patient to absorb shocks is minimal. And so literally, this is why you see people, they have difficulty walking down a ramp because it hurts too bad. If they had more ability to absorb the shock, they wouldn't. But with no ability to absorb shock, every single vibration that goes through their body hits them, and it hits them like a ton of bricks. The other thing, of course, with osteophytes obviously are a deformity of the joint. That deformity can cause a lot of issues depending on where the osteophyte is. The osteophytes grow very, very large and many times very quickly in late stage osteoarthritis. And I'm going to show you also how to intercept that immediately, because if I know here, we know TGF beta is actually driving the osteophyte formation. I know that if I stop TGF beta, I can stop the osteophyte from growing. And if I can take down the other cytokines in the joint, I can have it reabsorb. And that's one of the coolest things you can do is people come in with osteophyte, it's like, oh, it really hurts. And through your therapies, you can actually reverse it for them, and they don't hurt anymore. And they think you're like your magician, but it's just because you know the knowledge of the joint. So let's talk a little bit about TGF beta. Let me just rehydrate real quick. When you look at TGF beta, what's happening is that elevated TGF beta levels are causing, we know, extensive fibrosis in the synovium. We also know it's reducing flexibility. This is what's driving stiffness. And we also know that basically the high levels of TGF beta are actually activating type 1 collagen synthesis, which is okay. But remember, type 2 is really what we want. We want the hyaline cartilage, right? We want the clear cartilage we can see through, the type 2. We don't want the thicker cartilage, type 1. But I mean, I guess some cartilage is better than none. But unfortunately, that other cartilage is causing thickening of the joint tissues. What ends up occurring also is that you get a persistent pro-inflammatory cytokine expression. So in people that have late stage osteoarthritis, you go and you take a little bit of synovial fluid, sent to labs, you're going to find very high levels of interleukin 1 beta, TNF alpha, interleukin 6. And so you have a chronic inflammatory environment. This is also why they hurt so much. And this is why, for example, in the past, I'm sure people have done steroid injections, right? So if anyone has done a steroid injection, the reason why the pain goes away from the steroid so quickly is because you're basically intercepting the cytokines. Because these high levels of cytokines like interleukin 1 beta, TNF alpha, et cetera, those are actually causing the chronic inflammation. We know that whenever we get to this late stage osteoarthritis, because TGF beta is constantly elevated, because it's sensing, hey, our joint's damaged, please repair it, please repair it. Keep sending that out over and over. What's happening is that we get the elevated MMP, which is dissolving the cartilage. We get an enzyme called aggregatase, which is actually an enzyme that eats up aggregans, which are one of our favorite proteoglycans that holds in moisture into the cartilage. It allows the cartilage to deal with increased levels of compression, like, for example, during running and these kind of things. And all of this is contributing to this wear and tear that is occurring and is causing literally the joint to disintegrate in front of your eyes. Take a look at this image here. On this image on the left-hand side is a healthy joint. On the right-hand side is osteoarthritic joint. Notice that TGF beta is on both sides. At low levels, TGF beta actually helps us. At moderate and high levels, look at what TGF beta does. It actually hurts us. It makes the joint thicker, destroys the cartilage faster, causes new cyst formations, causes new osteophyte formations, and causes sclerosis. So it's really important to realize that TGF beta initially is kind of like our friends. We don't want to mess with it too much. But when we start to prolong, as osteoarthritis starts to advance more, particularly at the end of the early stage of osteoarthritis, TGF beta becomes our enemy, becomes something that's hurting us. The other thing that happens, of course, is that most synovial macrophages, in this case, in end stage or late stage osteoarthritis, they're in an M1 state. So the macrophages themselves that are meant to help us destroy debris, et cetera, they're now pumping out inflammatory cytokines themselves. And so this is further perpetuating the inflammation. And this is why it's getting so hard for the joint to repair itself. Even minor injury, minor issues that would have happened to the joint in the past that could have been easily repaired were now major issues because the joint is completely full of inflammation. Everything, our normal physiology is not working like it should. And we're actually getting to a point where we have an environment that's almost impossible to repair tissue in. Here's just a quick example of some interesting things that happen, especially in late stage osteoarthritis. We see what's called apoptosis. So when a cell commits suicide, if you will, a cell will actually kill itself or die from a stimulus. What happens is that you can see here over time that you can have things that actually introduce apoptosis, like reactive oxygen species, nitric oxide, these inflammatory cytokines that are being released by the stimulation of TGF beta, but also from mechanical stresses, from macrophages, et cetera. And what ends up happening to those chondrocytes or cartilage cells is that they end up releasing this thing called caspase-3, and they actually end up dying. They actually kill themselves. And so literally this is what's causing the osteoarthritis to occur. So often, and at least the way I was taught in medical school was that, hey, this is a wear and tear arthritis, right? Osteo is wear and tear. So this is a mechanical issue. The joints is rubbing, and when the joint rubs, it's going to rub off that cartilage, and that's what's happening. It's not quite true. The fact is that in fact, I would say it's 70 to 80% of it is immunohistochemical, meaning like it is related to these chemicals that are being released that's actually causing the damage of the joint. It's not just mechanical. And so that's why I want to make sure and share this model with you, because once you realize this, then you realize, whoa, if I can modify these cytokines, if I can take care of TGF beta, then I can change the entire future outcome for that joint. And that's what we're going to talk about. So when we look at in early stage osteoarthritis, what can we do to fix somebody who has early stage osteoarthritis? We know we got cartilage softening. We know we got joint space narrowing. We know we got synovial fluid. We know we got changes. We know we have TGF beta at a low level initially, but at the end of early stage arthritis starts to get really high. We also know that we have chondrocyte activation, which is okay, but then we have a little bit of like a low level of inflammatory cytokines, not terrible at early stage. And then you have a little bit of activation of MMPs, which are starting to facilitate the turnover of the extracellular matrix. But as we get to the end of the early stage arthritis, those MMPs are starting to come to a point where they're starting to degrade the cartilage as well. So literally the very thing that our joint was using to heal itself, those processes are now being used to destroy itself. And this is where we can come in and change that. There's a whole bunch of things you can do, and we'll talk about each of them in detail in a second here. But number one, of course, you can use hyaluronic acid. You can use angiotensin receptor blockers. We'll talk about how to use that in joints with TGF beta. We'll also talk about using frequency-specific microcurrent. A lot of these technologies are well studied. They're actually well reviewed. They're not extremely popular for a lot of reasons, but you can do some really interesting things with frequency-specific microcurrents. Also, you can use PMF. If you haven't used PMF, you'll know that PMF is extremely powerful technology if you use correctly and if it's used by someone who understands how to use it, which is probably like 10% of people using it. So, just saying that. And of course, you can use PRP as well in the early stage. So talking about HAs, what's happening when you use HA is that the HA enhances the viscosity of the synovial fluid and provides that lubrication, which is really critical. It also has a shock absorbing capacity as well. And HAs can be used in every, and we'll see later, but can be used in every stage of osteoarthritis. It's just a very useful intervention. It's extremely valuable. And they have a little bit, I'd say, very minor anti-inflammatory effect. They're not nearly as powerful as some of the other drugs that we have and other technologies, but they do have a very minor anti-inflammatory effect that occurs because they inhibit the pro-inflammatory cytokines IL-1 beta and TNF alpha, and this reduces the production of the MMPs. And remember, when we get high levels of MMPs, what do we have? It basically it degrades the cartilage extracellular matrix, right? The other thing that's kind of cool is that HA actually can bind to receptors on chondrocytes. Receptors, the chondrocytes themselves actually have a receptor just for hyaluronic acid, and it actually stimulates them to actually make more production of the extracellular matrix and try to not kill themselves as much through apoptosis, right? So just having HA in the system in every stage of osteoarthritis is good for the chondrocytes. So that's why if you look at HA research, what you'll find is American Arthritis Foundation, the 501c3 nonprofit, ultra pro HA. I know there's been, sadly, with the insurances and the governed care, of course, they've cut back on a lot of the HA stuff. But from a scientific point of view, hyaluronic acid is extremely useful. Here's a couple references if you're into doing some research. I thought these articles were probably the best out of HA to kind of explain everything. Just thought it was kind of cool. One's the first, of course, the first trial of Halligan. Not saying Halligan's the best one out there. I personally use Genvisc, but it's interesting to see the first trial, how beneficial it is, and then also synovial fluid analysis in osteoarthritis. A lot of research comes from that, and also shows the importance of HA in terms of modifying inflammatory cytokines. The other thing that's not really well known, but it's kind of cool, is that you can use angiotensin receptor blockers, ARBs, like losartan. You can actually inject this into joints. And there's been actually studies showing this, as well as dosage and everything like that. And we can, if you want to ask more technical questions, we get into that stuff too. But what's really cool is that TGF beta, remember that guy that stimulates, like initially at low doses is good for us, at moderate to high doses bad for us. ARBs can actually block TGF beta. And if we block TGF beta, it stops the cascade that we saw in the moderate and severe osteoarthritis. So there's some argument as to when to start angiotensin receptor blockers, but they can be delivered intraarticularly. And just to give you an idea, like the actual dose of an angiotensin receptor blocker, for example, for a knee, is roughly about 1 milligram. So we're not talking about a huge dose of this, right? And I have a whole mathematical model if you need it that shows you exactly how to calculate the dose you need depending on the joint space, et cetera, and the surface area of the joint, because basically you have to calculate the surface area of the joint and then figure out your dosage from that. But basically, you can actually completely halt the degenerative process of osteoarthritis by using angiotensin receptor blockers intraarticulately. Now, of course, anytime you use a drug intraarticulately, you have risks, right? I mean, go through some of those risks, but some of those include joint irritation, et cetera. But it is interesting to know that you have that ability now to literally stop the cascade that destroys the joint. The other thing that's really cool is that by reducing the oxidative stress and inflammation, ARBs or angiotensin receptor blockers actually help the chondrocyte get healthier and actually stops the degradation of ECM. And this basically essentially allows the cartilage to become, let more and more resilient to a lot of the effects that are occurring to it. As you might imagine, it's really hard for the cartilage to do its job in terms of being able to deal with, shear forces, stress forces, running, walking, etc., if it's being degraded by enzymes, right? So, I mean, it's pretty hard to do your job if you're being covered in acid that's eating you alive. But if I can get the acid off of you and you're not burning, then you can do a pretty good job. Well, that's what happens here to the cartilage as well. The other thing that's really cool about TGF beta and why it's extremely useful, particularly at the end of the early osteoarthritis phase and in the severe osteoarthritis phase, primarily, is that it stops fibrosis. The fibrosis that occurs inside the joint is very significant and it takes a very long time to recover. I've had people that come with severe osteoarthritis, and after like a long time treating them, their joint looks like the way it did before osteoarthritis. But one of the last things that we should get done is to get rid of all the fibrosis because fibrosis is very tough to reabsorb, number one. Number two, it causes severe stiffness in the joint. And this is why even sometimes after you treat patients with hyaluronic acid and steroids, etc., you'll notice that they still have stiffness. That stiffness is due to the fibrosis of the joint. If you eliminate or stop the fibrosis from occurring, you stop the stiffness, you stop that issue they have that reduces their range of motion, that makes their life a lot harder because their joint is literally thicker, right? And it take the joint itself will eventually reabsorb this if it is balanced. If you balance the cytokines, the joint itself will really fix this over time. But the more you can prevent it from happening, it's way easier than trying to reverse it later. So a couple references that I thought were cool for ARBs are right here. And if you guys want, I'm happy to send you a document with all the references as well. This is a little bit different here. If you guys know about frequency-specific microcurrents, kind of interesting technology. Basically, as you can see here, you got a positive pole and negative pole. And basically, microcurrents, these are in the microampere range. So there's nothing that can shock anybody or kill them or anything like that. You're very, very low dose that you're using. But when you use that, what's happening is you create a bidirectional ionic current between these two poles. And a lot of things happen that are unexpected. And so you see immediate change in the inflammatory mediators. Just by applying frequency-specific microcurrent, you can completely change the way that cytokines are expressed in whatever your target is. This is why FSM is such a useful treatment. It's not well understood. There's a lot of people that misuse it. They're not doing it right. There's a lot of, scams and stuff out there, just to be straight with you guys. Like people selling machines that probably not, like you can build an FSM machine in your house if you want to. Like, not that technically hard, right? So like just to let you like just realize that basically technology is very useful. Make sure you get to the right place that gives you the right machine and watch out for scams. But you can see how basically if you use FSM, you can actually stop pro-inflammatory cytokines like interleukin 6 and interleukin 8, and you can actually inhibit them from being released, which completely changes the health of a joint. The other thing that's really cool about FSM, which is very, very useful, is that it stimulates ATP production in cells, particularly chondrocytes, who are usually under a lot of stress, right? So if you have somebody who's in early stages of osteoarthritis, that chondrocyte's under a lot of stress. It's being eaten alive by MMPs. It's being, especially if it got to moderate and severe stage osteoarthritis, they're being, their apoptosis pathways are being triggered. There's extreme physical stress on the tissue itself. There's shear forces going on within the joint. Anything you can do to help that tissue be able to make more energy will allow that tissue to survive longer and reproduce more. And of course, most importantly, FSM is really great for pain control. And why does it work well for pain control? Because it modulates cytokines. That's one thing I just want to hit on a lot is that, as a pain guy myself, so I'm anesthesia pain, right? So as a pain guy myself, I've treated thousands of people with pain. And so often, unfortunately, there's so many doctors out there that they don't understand that if you remove the inflammatory cytokines, that you will decrease the pain for the patient. And so that's why steroids work. That's why certain interventions, like, that's why anti-inflammatories help, right? So the more that you can change the inflammatory milieu of the cell, the more that the patient will not have pain and be able to have increased function. And FSM is kind of a cheap way to do that. It's very effective, and you can do it multiple times. Here's a couple references for frequency-specific microcurrent. There's a lady who was actually a chiropractor back in the 90s who actually kind of, I would say, like, I don't say she discovered it, but she spearheaded this. FSM technology, I think, was created back in the 20s. But basically, she started using this in her practice as a chiropractor. She wrote several books on it. This is her name, Mick Macon there. That's her. This is a great article if you get a chance to read it, because what they show very clearly is that by using FSM, you can completely change the inflammatory cytokines in any tissue, by the way, depending on the frequency you use, which is kind of cool. The other technology that's also not commonly used in mainstream medicine, probably you guys are using it because everybody here is fairly advanced, is PMF, pulse electromagnetic frequency, right? Or pulse magnetic fields. This technology has been around for a long time. Just to give you an idea of how available it is, but it's not used, almost anybody who has ever done nerve ablations. So if you ever have done a radiofrequency neurotomy of a spinal nerve, if you ever did any kind of ablation that uses radiofrequency technology, you'll notice that almost all the machines, like 90% of them, Every Stryker machine, for example, has the ability to use pulsed electromagnetic fields to treat pain. This is incredibly effective, been around for a long time. This is actually how it works, though. It's kind of cool because it actually stimulates chondrocyte activity in the joints, and that helps produce ECM. The other thing that's really interesting about PMF is that it decreases the inflammatory cytokines as well, particularly interleukin 1 beta and TNF alpha. And because you intercept those inflammatory cytokines, it basically inhibits a lot of the catabolic enzymes like MMP that eat up the tissue that we are hoping to save. And then, of course, what's great about PMF is that it decreases pain. So it's not 100% sure, it's not 100% understood exactly how it does this, but it's thought that basically through changing the membrane potential of cells, that basically it's, stabilizing these cellular membranes, but it decreases pain. And I'll tell you that the first time I ever used this, I was, a mainstream medicine doctor working in a hospital doing procedures on patients, and I had a patient where we did an ablation, and basically the ablation was successful, but the patient still had pain, which is not that it can happen after ablations, right? Particularly after chemo ablations, like if someone uses like an alcohol derivative or something to burn away a nerve, like that's very common to have pain afterwards. And I used the PMMF, and the guy's pain went away 100%. It was actually more effective than the ablation. So it was kind of interesting. So very, very powerful technology that's surrounding us, but it's not commonly used. Here's a couple references in case you're into that for this. And then let's talk about PRP. I'm sure everybody's very familiar with PRP. We all know that PRP has platelets, and inside the platelets are granules. Inside those granules are cytokines, right? And that's what we're really using when we use PRP. PRP is ultra effective at a lot of things, particularly in younger patients. It does contain very high levels of growth factor, including PDGF, TGF beta, the one we like in low doses but not high doses, and IGF-1, insulin-like growth factor 1, which are very useful, particularly in joints at stimulating collagen synthesis. It has a moderate anti-inflammatory effect, I'd say. And you'll also notice that as we talk at each intervention, you'll see how we use PRP initially in early stage osteoarthritis, but as we go later and later, we start to use the modifications of PRP. For example, PRFM and PRF as well, particularly in late stage osteoarthritis. But basically, by using these anti-inflammatory effects, it gives some pain control to the patient, helps decrease the inflammatory state inside the joint. And of course, PRP is really cool because it basically supports extracellular matrix synthesis and slows down any inflammatory issues as well. A couple references, should you decide to check them out, that's awesome. If not, no problem. Let's go to moderate stage osteoarthritis, and this is what you're going to do to fix moderate stage osteoarthritic patients. We know that in moderate stage osteoarthritis, we have a lot going on. We got significant cartilage erosion, starting to be pretty bad. We got pretty significant joint space narrowing. We got new osteophytes that are coming up. Here's what's happening from the immunohistochemical side of it. We're having elevated TGF beta levels. We got a huge production of inflammatory cytokines. If you ever want to see this, take a sample of synovial fluid, send it to the lab. They can run this and they can actually tell you what the levels of cytokines are inside the joint tissue. You'll see a massive increase in inflammatory cytokines between early stage osteoarthritis and moderate stage osteoarthritis. Because of these inflammatory cytokines, you're going to get more and more of the degradation of the extracellular matrix, which of course destroys the cartilage, which then leads to decreased production of the proteoglycans. And it also damages the synovial membrane, which leads to decreased production of synovial fluid. This is why you get the joint space narrowing, right? So you also get, unfortunately, the profibrotic shift, which is something we want to avoid because we know fibrosis leads to stiffness in joints and damage of the ability of the joint to perform its function, particularly its range of motion. And of course, we get enzymes here, basically here called aggregations that actually destroy our favorite proteoglycan, aggregans, which actually helps a lot with shear forces inside the joint. So a couple of things that you can do for moderate stage OA, you can do HA injections, PRP injections. And notice here, we're going to start to include, now we're in moderate, we're going to start to use PRMF, right? Or PRFM. So platelet-rich fibrin matrix. This is basically when you take PRP, you're going to add a little bit of calcium chloride. If you guys need the formula for that, I can show you how to do that. But basically, essentially, you shift it into a matrix, essentially a matrix-like state, which can be a little thicker. And the PRFM, in general, you want to try to inject it fairly quickly into the joint because it can actually harden. But it has been shown that it releases cytokines greater for longer time than PRP, which is kind of better for moderate stage osteoarthritis. And now you can start to work in your biologics if you want to. You can use things like Warden's jelly. As you know, Warren's jelly is derived from umbilical tissue. It's very high in anti-inflammatory cytokines, growth factors, and it includes extracellular matrix protein, which helps, a lot of the cushioning because we've lost that now in moderate stage osteoarthritis. The other thing, if you guys are not familiar how to do it, is alpha 2 macroglobulin. If you're not using this, you should. I don't think you need to buy, like, just to be real here, we're all doctors here on the thing. There's so many people that want to sell you machines. Everybody and their brother wants to sell you a machine, and they're all expensive. You can use your brain and you can use some basic science. And if you need help, I have a document showing you how to do this. But you can also harvest alpha 2 macroglobulin on your own with a simple centrifuge. If you have a basic centrifuge, you can do this on your own. Yes, there are other kits and stuff you can buy, usually at very elevated prices, to do this. And perhaps those kits give you more of a pure A2M. That's true. They might give you more of a pure, but in some cases, it's easier for you just to use your own centrifuge to develop your own A2M. It's extremely effective. We do it all the time. And there might be a way that you can concentrate it down by using a fancy kit. That's totally fine. But I think what you'll find is that your cost factor to produce A2M is roughly $6 if you don't use a kit. So significantly less. The other thing that's really cool is that as we start to go into more regenerative medicine, we can use secretomes from placenta-derived sources. And this is kind of, I didn't want to specify any individual products here, particularly, but basically, when you look at the placenta, it's a whole world of things that we can use to repair tissue. And I could probably talk for an hour about placenta-derived stuff, so I don't want to bore you with all stuff, but just realize that the various products that are derived from placentas can be plugged in immediately to certain issues that you are facing with your patients that will allow you to modulate the immunohistochemical response that's going on in their tissues and completely change the outcome. So, for example, you can use secretomes that have growth factors, cytokines, and microRNA. And so these different secretomes that you can select, like there could be protein arrays, they could be, various forms of exosomes that you can derive from different types of placental tissue that have different factors. And please remember that the placenta has three germ lines, ectoderm, endoderm, mesoderm, and that you need to know where these placenta-derived sources come from because each of those different germ lines will affect tissue differently. So, for example, if I use a mesoderm-derived placental tissue, I can do really great things with mesoderm-derived structures. But if I use a mesoderm-derived placental tissue or derivative, and I try to treat an ectodermal-derived structure, the effect will be very minimal. And so realize that you have to match, mesoderm to mesoderm, ectoderm to ectoderm, endoderm to endoderm. Or there are some products, for example, that are ultra flexible that have all three germ lines in there. And this is like into itself a whole different thing. But, basically to kind of boil it down into a nutshell for you, if you take a placenta and you put it into a bioreactor, you keep that placenta alive, the placenta can generate anything you want from it. And from that, you can get anything that you need to repair patients. So that's a whole different, lecture or whatever. But basically, just realize that you can start to use this in moderate stage osteoarthritis, and there's a lot of cool things you can do. And as you guys know, of course, we can always use the FSM and PMF to help out, and those are very useful. Those are great technologies that can be delivered, even not by you, maybe by your assistant, by a medical assistant you train, nurse practitioner, whatever you like, or a chiropractor. A lot of times you can make a deal with a chiropractor, by the way, and they can do it for you. Um, the HAs, as we know, in moderate osteoarthritis, very useful. We know that they provide joint viscosity, they provide fluid, they increase lubrication, they stop the inflammatory cytokines, they help stimulate ECM, etc. We also know that they do chondrocyte protection, etc. We know HAs are great. That's awesome. We know about PRP. We know about PRFM. We know they're anti-inflammatory, so those are very useful. And Warren's jelly is pretty interesting. Warren's jelly is derived from the umbilical cord. It contains, in some cases, mesenchymal stem cells, but to be real, depending on the product you get, most products you buy regenerative medicine wise do not have live cells in them. Usually they're very old and the mesenchymal stem cells are dead, just to be straight with you, okay? If someone's telling you they have a ton of live mesenchymal stem cells in their product, chances are they're lying to you. You can always ask, you can say, hey, do me a favor, give me a full report and give me a flow test. And they can basically show you with a flow test how many live cells are in there. And what you'll find is that, there's probably not going to be many. There are certain places where you can get high quality Warden's jelly that still has live mesenchymal stem cells in it. But those are for research only, of course. And the thing is that they're usually more expensive than, whatever the salesman is coming to sell you the product. So realize that in general, when you use Warren's jelly from a salesman that comes to your office or from one of these labs that's out there, the only thing you're going to get the anti-inflammatory cytokines, which are very useful, by the way. So there's nothing wrong with that. But realize the mesenchymal stem cells are probably not there. We know that Warden's jelly has a very powerful effect on chondroprotection. So that's why Warden's jelly is so good in joints. Warden's jelly, being an umbilical cord derivative, by the way, is a mesodermal derivative, which means it works great on mesodermal structures like the knee, like the joints, like muscles, like tendons, etc. Right? Um, it also contains hyaluronic acid, collagen, and includes its own proteoglycans, which is awesome because those are things we lose in moderate level osteoarthritis, right? We also know that it inhibits fibrosis, and of course, it improves pain control. Here's a couple of references. Should you like to see them? And then let's jump to alpha 2 macroglobulin, extremely useful, as I mentioned before. What's really cool about A2M is that you can drive it yourself from the patient's blood. It's not hard to do this. Yes, you can buy kits and stuff like that if you wish. I'm not putting those kits down. You'll probably get a more concentrated product by using the kit, but I ask you to consider what is your cost benefit ratio. And I think if you consider that, it'll give you the right answer. But basically, the A2M works so well because it inhibits the catabolic enzymes that are destroying tissues. And that's why now at the moderate level of osteoarthritis, we can start to use A2M because at this point, our catabolic enzymes like MMPs, aggregationase, agglutinases, and atoms basically degrade collagen and proteoglycans. So by neutralizing these enzymes, the A2M is really very useful. That's about all that it really does. Like it has anti-inflammatory effects that's very minor. It does have chondrocyte protection effects as well. But in general, the most powerful part of the A2M is that it inhibits those proteases that are literally like acid dissolving the joint. And as you can see here, pretty much all of its effects are essentially derived from the fact that it's able to inhibit those proteases. Here's a couple references. This guy Wang, by the way, is a great researcher. If you're ever interested in like following up on his articles, they're all pretty good. Now jumping into some of the regenerative medicine effects, we have placenta-derived secretomes, and I use that as a kind of like a catch-all phrase because that includes anything like most products that you might use that we considered regenerative medicine would fall under the category of what we consider placenta-derived secretomes. So whether it's an exosome, whether it's a Ward's jelly, whether it's amnion, whatever, these are all placenta-derived structures, and a lot of them are secretomes. If you're actually using real placenta tissue, that's a whole different ball of wax, but definitely something that can be done. You have to watch out for the side effects of that, of course. But in general, kind of with you're talking about regenerative medicine, this is kind of like a catch-all phrase for it. If I take a placenta and I derive secretomes, or I ask the placenta, please make me the things that you release to keep yourself alive from the amnion and chorion, what I get is I get a very powerful anti-inflammatory mixture of cytokines, growth factors, and extracellular vesicles like exosomes that can reduce inflammation and have a significant effect in modulating the inflammatory response inside the OA joint. And that's why so often you have patients that, and this is you'll see people all the time, like I see doctors all the time that are, hey, I had a patient, they have osteoarthritis in the knee, I injected these exosomes, they got better. So therefore that means their product is awesome. Not exactly. You need to understand what your product is. One is where is your product derived from? Two, if you have what's called an extracellular vesicle, like an exosome, what's inside the exosome? It is so disappointing for me to see things like last time I was at the uh, meeting in Miami, and there was all these exosome companies. I've got 8 billion, I've got 9 billion, I've got 10 billion. Exosome means envelope, right? That's what it really means. What's in the envelope is what matters. Having a whole bunch of envelopes doesn't mean anything. Exosomes come from all cells, by the way, including cancer cells. So knowing where your exosomes come from, the tissue it comes from, and what's inside the exosomes is critical before you ever use it. So please make sure that you understand if you're going to be using any regenerative medicine products, you understand where they're from and what's inside of them that's making them work. Because now that you have this model, you can now be able to use that to basically modify how joints work. And then there's other models we have. For example, you guys were talking about brain fog and stuff like that before. We've had amazing effects because the reason why a lot of people have brain fog is that they have neuroinflammation. And if you wish to find this out in any patient, consider just doing something simple as a spinal tap, right? You take a spinal kit, go into the spine, take out some CSF, send it to lab. You will be able to request all of your cytokine panels, etc. And what you'll find is that they have very high levels of inflammatory cytokines inside their central nervous system. And as soon as you correct that, you get amazing results. We talk about that later if you want. But this is the same kind of idea here. So we know that placenta-derived secretomes have a lot of growth factors that help us. They also can prevent fibrosis by modulating TGF. We also know that they are very anti-inflammatory. They can improve a lot of the pain and decrease stiffness in the joints. A couple of references if you want that. We kind of already talked about FSM and PMF. We know that they're very useful. We know they increase ATP production. We know they can modify inflammatory cytokines. So if you're not already using these, consider using them. There's no, I think somebody put in here on the chat something about who does this work in New York. I'm not sure what that, there may be somebody who does FSM and PMF, but like as a physician, I'm in Texas, so it's, I mean, let me qualify. So as in Texas, I'm not in New York, so I don't know. But in Texas, I can take anyone off the street, I can train them, and they can work as a medical assistant under me, and they can basically execute my orders for me, but I do take full responsibility for them. FSM and PMF, FSM more complex than PMF, but PMF, for example, could be completely done by a medical assistant. You can also find a chiropractor to do it for you as well. So I would, you can also do it yourself if you wish. Maybe initially first do, especially with FSM, it's probably the best for you to learn by doing it yourself. But these are all things that you can do, and they have dramatic effects for the patients, and patients get so much better so quickly. Um, and so let's jump over to late stage osteoarthritis, and then we'll have a summary of all of our interventions. This is your classic picture of a late stage osteoarthritis, right? You got a person here, they're totally bone on bone. Notice we have this great white stuff here on this x-ray. What does that indicate? If anybody wants to put in the chat or say out if you want to.
Osteophytes.
Exactly, sclerosis. You got it. So those are sclerosis, and that is because the bone has gotten more dense. And then you can see here on the edge, we're starting to get an osteophyte form as well. So you have complete cartilage loss when you get to late stage osteoarthritis. You have severe joint space narrowing, as you can see there. Just imagine trying to walk on that knee, how painful that is. The other thing you start to begin to see is you get the sclerosis you see there, but then you also see bone, basically, you get the bone sclerosis, but you also see osteophytes form. So you actually have new bone growth that usually comes on the outsides here. I think see here, pretty significant. And these osteophytes can, most of the time when they're small, they're not a big deal, but as they enlarge, they can cause a whole bunch of issues. They can even tear through external ligaments. For example, you can get an osteophyte that tears through your lateral collateral ligament of your knee. As you might imagine, that's extraordinarily painful. The other thing that happens in late stage osteoarthritis is that our TGF beta is out of control. It is ultra high. And because it is high, it is causing massive amount of fibrosis and a massive amount of inflammation, which is leading to extreme joint stiffness. This is why you see the people when they have late stage osteoarthritis, they're so stiff, it's hard for them to do anything, right? At this point in the osteoarthritis cycle, you have essentially persistent elevation of inflammatory cytokines. And this is why a lot of people who are late stage osteoarthritis don't respond well to cytokine modulators that are not powerful. So, for example, if you put in like a weak steroid into someone who has osteoarthritis, they'll get a few days relief, but it won't last. If you try to give somebody with a severe osteoarthritis a hyaluronic acid injection, which is a very weak inhibitor of inflammatory cytokines, the lubrication part, dealing with shock absorption, those are all useful. But as HA is very, very weak in terms of the way it's able to decrease inflammatory cytokines, like they will have no effect from it because their levels of inflammatory cytokines are through the roof. And this is why you see when you treat people with advanced stage osteoarthritis, a lot of the classical interventions that we were taught maybe in medical school or residency, they don't have much of an effect. And if they do, it's very short-lived. We can reverse this though, as well, and we'll talk more about it. But the other thing that's happening is you get a lot of chondrocyte death and you have massive amounts of oxidative stress. And this is why sometimes, for example, if you use things that increase the ability of the body's ability to deal with oxidative stress. So, for example, you give like NAD infusions, you give infusions of like Myers cocktail, you give infusions of, blanking on it now, the injectable. There's an injectable, oh, I'm blanking on it. There's an injectable anti-inflammatory that you can give as well. And basically that injectable anti-inflammatory will help reduce the oxidative stress. You'll get some improvement in some of these people, but usually it's very short-lived as well. A couple of things that you can do for late-stage osteoarthritis is you can use Warden's jelly if you wish. Very powerful. Placenta-derived secretomes. Some of these are actually like some of these secretomes are actually more powerful than Warren's jelly, depending on. This is kind of a catch-all, as mentioned before, but those are very powerful. Notice now, because we're moving to late stage, what's coming up first are the stronger things that we're using, right? We don't see PRP on here. HA is not the first thing on here. We're starting to use more advanced things because we know we have such a high level of inflammatory cytokines that in order for us to make any difference, we got to bring that down first. And that's why you see these as number one and number two. ARBs are particularly useful at this level, by the way, because they can completely inhibit TGF beta. By the way, if you take an ARB and you inject it into a joint, it lasts for 11 days. Its effect for inhibiting TGF beta lasts for 11 days. So it's not like it lasts forever, but it does significantly decrease that. So it can be very useful. Alpha 2 macroglobulin, why not? Especially if you can drive it from the patient's blood for $6, kind of makes sense. And then now notice we're not using PRP anymore. We're using platelet-rich fibrin, which is kind of that real thick clot that develops if you put the patient's blood into a centrifuge and you spin it without any anticoagulant, you get this really massive yellow-looking clot. That's what PRF is, right? Then you have platelet-rich fibrin matrix, which is where you take the PRP and then you basically will add calcium to it and basically make it into kind of a matrix. And there's different derivatives of PRFM, by the way. And one was commonly called Cytorejuve, is a little more liquidy than the others, which is better for joints. But we can get into that if you ever have questions. But basically, by using these two, you can really help a lot. And then finally, you can use our friends, the PMF and FSM, always useful for every stage of osteoarthritis. And it's kind of delving each of them. We know that Warren's jelly, I'm kind of familiar with it. It's very powerful at this stage because it is a mesenchymal derivative, as most joints are. And then we know that basically, like using placenta-derived secretomes, at this level, I put in including microRNA. Depending on the secretome you choose, most secretomes that you buy, like exosomes, et cetera, don't have microRNA in them. There are some that do. But microRNA is very, very powerful in modulating inflammatory pathways. It can reduce pro-inflammatory cytokines significantly. It also has the way to modify way proteins are expressed and even modify post-translational proteins. So literally, there are microRNAs that affect the endoplasmic reticulum of the cell and modify the way that proteins are being folded. You might imagine that'd be pretty useful for some neurologic stuff, right? Like Alzheimer's. Yeah. So anyway, basically like you can use these microRNA. The ones you're looking for here for the joints are like 140, 146 alpha. And they're very powerful as you might imagine. The other thing you see is microRNA 21 is another good one. But basically they have chondroprotective effects on the cells and they can actually change the way a cell behaves completely. A lot of cells that get damaged by inflammation, they become almost a senescent state. Like if you look at the cell under a microscope, you see a cell, it's alive, it stains alive. Like if you put a stain, you can see that something's happening in there, but it's not nearly the same as the cells surrounding it. You see that what if you look more detailed, what you find is that even the expression of the cell's natural proteins are decreased. And so the cell, many times, not even repairing its own cytoskeleton. The cell looks very strange. It's not part of the same organization. The tissue organization is starting to degrade. Um, you can reverse some of this by altering microRNA. MicroRNA is very, very powerful. And so there's certain products that are placenta derived that you can use with microRNA, and you can make dramatic effects on tissue, particularly long-term effects, because microRNA is not instant, but it lasts a long time. The other thing it can do, of course, is it can increase chondrocyte survival and increase the ability for the extracellular matrix to be supported, and it can decrease fibrosis. MicroRNA actually has a pretty decent effect on fibrosis as well. And of course, it can decrease pain as well in the joint. So here's a couple references for that. We know about ARBs already, particularly useful in advanced stage osteoarthritis. We also know about alpha-2 microglobulin, very useful at this stage. Why? Because it's mainly an inhibitor of the protease enzymes such as MMPs, etc. And then we know about PRF and plate-rich fibrin matrix, right? We know that, for example, that PRF and PRFM, they're natural matrices, which kind of help support the growth of the articular cartilage, because at this point in osteoarthritis, the cartilage is mostly destroyed. Most of the time, you have exposed subchondral bone. It's very hard for a chondrocyte to connect to subchondral bone and rebuild its own tissue. So by having a matrix that's constantly releasing anti-inflammatory cytokines is very, very useful. In the case of PRF, it literally is a matrix only. Like if you look at it, it's a big kind of yellow ball of, of clot, essentially. And that matrix is very useful to put over exposed subchondral bone. You can do this through injection. You can also do it through a scope, whatever you wish. But the thing is that these things really help protect that joint and help protect the subchondral bone. We also know that, PRF, they all, of course, have, anti-inflammatory effects. And then their biggest power is their scaffold for the osteoarthritis, right? Just to give you an idea, I thought this was a really cool picture here. So this is, we talked already about PMF and FSM, but this picture is actually immunohistological staining of PMF, patients being treated with PMF, and just look at how different this is. In this case, this is actually for bone growth, not for joint, but they actually use this for bone growth, and you can see just the amount, the effects that PMF have. This is one with PMF. This is one, obviously with and without. So you can kind of see the difference between the two, but it's amazing the effects that they have with PMF. So if you're not using it already, yeah, it's something to consider adding on to your practice. And then I have a quick summary of those. If you guys want a chart like this, it shows you exactly what to do with each stage of osteoarthritis, exactly how it works, and I have each different thing broken down, when you should use it, etc. If that's of use, then let me know. And then finally, what I wanted to say to you guys is like, I really enjoyed presenting here for you, and I'd love to share with you more information if you would like. I also have basically like an underground network of doctors that basically work together, and we share information, we share research, we conduct research with each other, etc. And if you'd like to join that, to help your patients, you can go to adamsewellmd.com/join, and you can join that. You fill out an application. There's no cost, but we can connect you to various funding sources for research, et cetera. And we can even do research with you. Or if you just want to be able to get the protocols that I have, I'm happy. I put them in this little group here if you wish, and you can join that at no charge at all. And our goal is to just have you get information if you want to, but you don't have to. And that's it. So I
Thank
know it
you
was kind
very
of
much
like a
for
whirlend tour there,
Thank
but
you very much, Dr.
let me
Adam.
answer some questions for you guys.
Yeah, thank you very much, Dr. Adam. Um, I like your presentation. It's very precise, clear, and it's on the point, and it shows all the mechanism of action, which is very, very important, especially for our groups. But I want to just add things and emphasize on things. First of all, if I go through your lecture, you will see that you are working with the same principles of chronic disease prevention management. You are restoring the metabolic, you're restoring the immune, as you see with the cytokine profile that you're doing, or modulations with losartan, for example, to inhibit the transforming growth factor beta. And you're doing redox, which you're using the energy therapies, whether it's EMF or the electrons, electrocurrent or microcurrent. Those one really affect the redox, and then it will affect the cytokines. It's especially the microcurrents, the electrons that neutralize the free radicals. And once you dump those pathological free radicals, you end up modifying the immune system and decreasing those inflammatory cytokines and irritation of the macrophages. EMF does the same thing. It opens up calcium channel, it causes influx of calcium, which leads to a spark of physiological free radicals, and that physiological free radical will stimulate the expression of antioxidants and anti-inflammatory cytokines. But it starts with redox, so I like to call all the energy forms of energy therapies work the redox. And metabolic, you can see that you're inhibiting proteases enzymes by those antibodies that you are doing. And it will be more effective, of course, if we load them with cyclodextrin to stabilize those antibodies from being degraded. And all the drugs, it can be loaded inside cyclodextrin. And also, there's a good complex that's happening, a very, very good publication, where you load the cyclodextrin with hyaluronic acid and you can get better even super networking or super viscous product that helps in lubrication. So adding cyclodextrin, doing platelets nanoparticle, loading it with drugs along with cyclodextrin, I think it will enhance the efficacy of it. You maybe need some light therapy there, photobiomodulation or photoregeneration therapies. But I know the lecture, it's, trying to squeeze the important part of it. But there's other form of energy. Light therapy is one of them that will help. Another form of energy, especially with osteophytes, is the ultrasonic, which is the shock waves. That helps to break down the osteophytes, and I think it's a good thing to add in the treatments of
Yeah,
especially the
I would
less
agree with
stage.
both of those. Like we do lose LLT therapy, and we also do extracorporeal shockwave therapy as well.
Right.
Um, Typically, like I'll say that I think that they're effective, but they're not as effective as the things we discuss. And so I wanted to kind of like show like this is if you had a patient coming in tomorrow, like what would you do for them? Like this will hopefully give you that answer.
Yeah, I mean, again, it's just more or less of integrating all those therapies, especially with stem cells. I mean, the Wharton jelly and platelets as well. They all have growth factors, so you are modulating the regenerative part of you can say with those growth factors inside the platelets nanoparticle. I see the presentation is great and it's wonderful. We were looking forward to collaborate with you and see how we can come up with some level of collaboration. But I would like to have the people here if you have any questions, any comments, anything for Dr. Sewell.
Yeah, Dr. Sewell, that was a great lecture. Very lots of familiar things in my world, but adding a lot of new things, a lot of details, mechanisms, um, even the energy treatments. I've been very interested in learning on a deeper level. I did have a couple of questions,
Sure.
and this one's just I'm just kind of throwing it out there, and it's a curiosity, and it's we don't have to prove it right or wrong, or but I'm curious in your experience or in your research. Um, Maybe this is more of an opinion. Do you think some people with osteoarthritis have some aspect of a low grade infection inside, like a chronic low grade infection, or say um, a bacterium or bacterium like species that maybe they just shouldn't be there, or somehow they got there? Fungal species, anything like that?
Yeah, it's a great question. It's kind of like which one came first, the chicken or the egg, right? Because we know that, like, in any form of, especially osteoarthritis, we know it's cytokine mediated. For many decades, we didn't know that. But we know now, for example, that all of osteoarthritis is very similar to rheumatoid arthritis in the fact that it is cytokine mediated. And so, as soon as you have inflammatory cytokines, like the levels that you see directly after early stage osteoarthritis, anything after that, the levels of cytokines are so high that whether it's hard to know, like, was the bacteria the one who caused the elevated cytokine levels, which then led to the arthritis, or did the elevated levels of cytokine cause destruction of the joint in such a way that now it became weaker and more prone to infection? But yeah, you're exactly right. There's always a correlation between those two. Just like you see with a patient when they get extra high levels of stress, right? They're more likely to be infected. And so I think you have a very good point, and it's wise to kind of tease these out because it wouldn't be uncommon, for example, for someone to have, severe osteoarthritis, then later develop an infection. Um, this happens,
Well, that's
Um,
the reason I think adding methylene blue, I think, I don't know if you hear about methylene blue, is being added to treat osteoarthritis. It's a redox modulator. And if you do methylene blue along with light therapy and activate it with red light, you can clear all this infection. And loading it inside the cyclodextrin and platelet nanoparticle, along with all the other drugs that you can put, including losartan, you can definitely come up with a very nice cocktail that is targeted and nanoparticle. But what's important here, I think this is a message I need everybody to clarify. Even if its cartilage is it's messed up, there is synovial membrane, which is very critical and important. That when we do regenerative therapy, don't just think about we're building cartilage because maybe the cartilage is not gonna be built significant or clinically significant. But there will be other part that we are working on, which is synovial membrane. It's been stunned by inflammation. They don't secrete any more synovial fluid. And with this therapy of anti-inflammatory and regenerative therapy, we are actually increasing this lubrication. And the lubrication will help enhance the efficacy of the treatment and decrease the pain, all that stuff. So I need everybody here. We're not targeting just the cartilage when we treat pain. We're targeting the nerve tissue. We're targeting the synovial membrane, and we help to restore all those structures to help in the lubrication and help to decrease the sensitivity of the pain. We also consider central pain versus peripheral pain because you manage the joint and still you have central pain. It's another part of the problem. But that's very important because I hear some people bone on bone and still they benefit from platelet nanoparticle. And people they think, well, are they building the cartilage? How does that work? I mean, what they're targeting? We're targeting really the synovial membrane to secrete synovial fluid and lubricate the tissue, even if it's bone and bone, and people get benefit from it. Do you concur that, Dr. Sewell?
Yeah, I think so. I mean, I think that will definitely help. And then I think like even methylene blue, we know, for example, inhibits MMPs, right? So like we know that that definitely is an effect of it. And of course, it's electron donor, which helps mitochondrial support. We know it does reduction of oxidative stress. So it's like this is very useful, for a lot of different things. But yeah, I totally agree.
Are you did any injection methylene blue in the joint? Not yet.
I do, but usually it's going to be like a tertiary therapy because what I find is that like while it may help, I feel like it's a power level is like I kind of compare it. I'd say it's like moderate to low. It's definitely stronger than like hyaluronic acid. But what I find is that in a lot of cases, the first thing I'm trying to do is I'm trying to initially inhibit usually the inflammatory process, and then my first goal is to get the inflammatory cytokines down because that way the patient is not in pain anymore. And that's usually will get you your first win. Because what I find is that, from a practical point of view, so like just taking the medical hat off, right? And just, as like a doctor, but also as somebody who runs a clinic, um, what I think we have to do is we have to also give an amazing patient experience. And if I can have a patient come in and they can get treated, and their pain goes from, whatever 8 out of 10 or 7 out of 10 to zero that first day, like they're going to be much happier and they're more likely to be more consistent with the therapy. And so I usually will use the methylene blue, not as the initial line, but I use it further down. But I do think you have a really good point. I mean, it is definitely a very powerful medication. It's being used for a lot of stuff now. Um, I would agree.
Right. Anybody have the questions? Audience?
Hi, I'm here for selfish purposes. I'm not a physician, but the story that Dr. Sewell was talking about on the patient, from the patient experience is something that I lived through. And honestly, now having very difficult time actually finding pain management doctors who are as proactive and really are focusing on patient experience, like Dr. Sewell said. A lot of times it's just very standardized steroids, anti-inflammatory, or oral injectable, and that's about it. So that's why I was kind of asking who in New York works with you as your colleague, because I'm actually interested in pursuing alternative modalities and looking to see what other options are available. Those that you described.
There is a guy that I know in New York that can do it as well. Um, he doesn't do everything that I do, but I mean he does a lot of alternative therapies that have been very useful, and so I could probably connect you to him. I put my cell phone number in the little chat if you want to just text me later. I'm happy to forward it to you.
I
And then
appreciate it.
probably imagine Dr. Alasa, you probably have somebody here that's from New York, right?
Are we talking about New York City or New York State?
New York City, Long Island, any in that vicinity?
The guy knows in Manhattan.
That's
I know,
perfect.
I know a really good physical therapist there that you may want to take a look at. If I can think, Troy Stallman, Stallman. He has people flying in from all over the world. He has some device I was planning on visiting a couple years ago that is different, but I never got a chance to find out what it is. But um, he's somebody I know that, at least from a physical therapy standpoint, could help that part of it. He's got some very interesting and some innovative strategies from a physical therapy standpoint.
Thank you. His name is Troy, you said, right? First name Troy?
Yeah, Troy, and then
Okay.
last is Stallman.
Yep, got it.
Okay.
Thank you. And they target different joints, not like hand joints, upper, lower extremities.
From my understanding, I mean, he's everything, the real deal.
Okay.
I mean,